Listen-only mode.
Good afternoon, everyone. Welcome to the Health Equity webinar, Taking the Next Steps, provided to you by the Community Health Training Institute, which is generously funded by the Massachusetts Department of Public Health. I'm giving people like another minute or so to sign on, and also because we officially start in a minute, but I just want to make sure you all can hear me as well, and we send a message to you telling you that. So let us know if you can't hear us. So again, we'll get started in a few seconds. All right. So welcome, everyone. My name is Daisy Ortega. I serve as the director of the Community Health Training Institute. I'm excited for today's presentation, as I'm sure you are as well. We are starting the Introduction to Health Equity conversation and engagement, and today's webinar is entitled Taking the Next Steps. So for the next hour and a half, we're going to have our presenter, Mo Barboza, really go into some critical topics around this piece. So really sit tight for that info. Just to get some logistics out of the way, if you're looking at the screen now, you're noticing we have some information there of a quick way for you to sign on to our email list. So just text training inst to the 22828 just to automatically be added. And of course, we're on Twitter, hashtag MA Coalitions, if you want to join in on the conversation or ask questions and comments there as well. So just to orient you to how webinars work, just in case, it's good to be on the same page. There's going to be a questions box so that you can submit your questions for anything that comes up for you during this presentation. We will have a Q&A at different points in the webinar and at the end as well, where we welcome your questions throughout so that we can get a pulse of how people are doing. Just to remind you, and I'll tell you again later, there will be a feedback form we're going to ask you to fill out, and that will pop up as soon as this webinar ends. We would really appreciate your feedback about today's content. And you will also receive a link with slides and the recording a few days after this webinar as well. So that will be coming into your mailbox in a few days. And again, we encourage you to use our hashtag and also send any comments to HRA Institute and Twitter. And again, here goes the question box in case you're not familiar. And I'm going to toss it over now to our wonderful presenter, Mo Barboza, who's going to get us started.
Well, good afternoon. Hope all are doing well. And I'm sure there's somebody for whom it's still morning. So good morning, all you left coasters. Wanted to just introduce myself. I'm Mo Barboza. I serve as Associate Director of Training and Capacity Building here at Health Resources in Action. I have the great privilege of working directly with Daisy, who's also an Associate Director in our department, and some wonderful folks on our team, including some of the folks that you may have been familiar with through the Community Health Training Institute. We're going to go ahead and get rolling. So we have some learning objectives, and these are familiar to you because you should have seen these on the flyer. Yeah. Describe the health equity and diversity in a community context. So we'll be talking a little bit about health equity and helping to define it, and also give it a space to really think about in the work that you're doing. We'll be describing some aspects of culturally competent approach to community work, and this is throughout the course of our time together. So I'll try to pull out a few places where some practices really lend themselves to helping us be more culturally competent, especially if we're working with populations across difference, and identifying some strategies for collaborative work. And this work in health equity really demands that we are purposeful in terms of being collaborative. How this will happen, we're going to spend some time defining health equity. We're going to name and discuss 4 key questions, and I like to say to folks, if you walk away with nothing else, walk away with these 4 key questions. And we're going to use some examples and discuss some practical steps. We'll be thinking about policy change and systems change, and leadership development is also the places where health equity can play a role. So, a few words on language. Some of you are public health people for a long time. You've been in the field, and you'll notice that these terms somewhat follow the evolution of the field in the last 20, 30 years or so. We were doing social justice for quite some time, and that's probably 80s, early 90s. We moved to thinking about environmental strategies, late 90s into the beginning of the 2000s, and that was the big thing. And then disparities also started to perk up, and in the last 5 to 7 years we've been really talking about the social determinants of health in a bigger way, and the last 3 to 5 years or so in health equity. So I want to say that there's a relationship among these, but these are not the flavors of the month. So we are no longer doing social justice or environmental strategies. We're no longer focusing on disparities or no longer working on social determinants of health to do health equity. These are additions to and different aspects of the work that we do. So part of defining health equity is to really see it as related to some of the other work we've been doing, but also where it is not related. So we'll be talking a little bit about that today as well. I wanted to start with a data example, and really important that our conversations about health equity are framed by our examination of data. This is data from quite some time ago, an area in southeastern Massachusetts in and around Brockton, and I want to thank our friends from the Southeast Center for Healthy Communities for this chart. It's basically looking at disparities in percentage of infants with low birth weight in Brockton, which is the major urban area in that local health network area, and then a few of the neighborhoods around there. The ways that we've been talking about data in the past would lead us to look at this chart and make some assumptions. We might look at this and say, well, it seems like in the city of Brockton, the issue is really with Asian population that's experiencing a much greater incidence of low birth weight. We might also look at this and say, wow, the towns outside of Brockton and around it, Black non-Hispanic population is experiencing a really high rate of low birth weight as well. It really means that we have to dig deeper, and part of what health equity is asking us to do is to disaggregate the data as you see here. So the infant mortality rate for Brockton was 8.3 per 1,000, which is much higher than the state at the same time, which was 4.9 per 1,000. That in of itself might have led us to think about some interventions across the board. And in the past, part of the work that we did obviously would have led us to some interventions that were across all these different ethnic groups. When we dig a little bit deeper, we start to see that there are some significant differences. And so, for example, if you think about the differences for Black and non-Hispanics in the towns around Brockton versus the state average and the Brockton average, there seems to be something happening there. Likewise, the Hispanic population in the towns around Brockton seems to be experiencing a much lower rate of this low birth weight in that population. That might also tell us something. And then obviously the Asian population has a high percentage in both outside of Brockton and in Brockton. These are all things that we would want to take into account. Local knowledge, however, will help us to make sense of what the data is telling us. And so part of what I want to submit to you is that part of working in a health equity frame is to really be thinking about the populations that these numbers are related to and what is their lived experience. What's going on there that we need to think about and we need to know, and the best way to know that is by engaging that population. That also happens to be one of the best way to make sure that we're being culturally competent is to have the vulnerable population, the population that is experiencing the disparity or the inequity, to be part of the conversation, because they could tell us, for example, the towns around Brockton where this Black non-Hispanic population lives have a different set of services and service opportunities for that population. They're not evenly socioeconomically distributed, and so that might be a factor in why that's a population that's experiencing low birth rate, their access to neonatal care, etc. Same thing with the Asian population. We might want to think about, is this something that's going on in Brockton? Is there a particular population? And it's a time to also check our assumptions and really make sure that we're not falling prey to the stereotypes that we unfortunately are all growing up with and all living our lives with. And so the Asian population, for example, some folks would jump at that figure and say, well, folks are smaller build, et cetera, et cetera. That may or may not be true, and it may or may not be true for this population, but it's not something that we can write off. We need to do the investigation and to look deeply into what's happening in that space. So I wanted to just start with that kind of framing of data, because any process that's thinking about health equity has to have data that's disaggregated and data that has with it a little bit of context from the actual space. Again, I want to thank our friends in the Brockton area for the use of their information. So I talked about developing a health equity lens, and the first part of that is really admitting, are we willing to see the disparities and the inequity? Are we honestly willing to take on the issues that this brings up? And are we willing to be seen to see it? And by that I mean that we will be accountable to others who then know that we have seen this disparity or this inequity, and that they will know that we are supposed to be doing something about it. And I want to be very clear about that. If for some reason you are not willing to be accountable for what you have seen, this may not be what you want to do. Secondly, we already talked about disaggregating the data, and this is to get down to the level of people's lived lives. So whether it's socioeconomic data, race and ethnicity, or other demographic data, we really want to make sure that we're able to look at the populations that are being served in a specific area, or the populations that are experiencing inequities, and be able to tell a story about them specifically. And it may take that you have to do some of your own data gathering, or you may need to look at some unusual sources for data gathering. I would say there's in this last few years, there's so many towns, cities, and hospitals that are doing health assessments, and other departments that are doing health assessments, that we may have better data, and a little bit of looking around might help you to find something that paints a more thorough picture of the populations that you are looking to address. And then last but not least is this idea that we need an analysis on race, power, and poverty, that the powers that created the situation that a population finds itself in today didn't turn up today, that there's a historical perspective, and there's a perspective about the ways in which power has played on and against certain communities, and that we have to be willing to name that that power that's at play and be willing to work on addressing it. So I'm going to start with an example. Most of you have probably seen this picture. Unfortunately, it's become an iconic picture of the tragedy of Hurricane Katrina and some of what happened in New Orleans and the surrounding communities, and the inequities that were present beforehand and were exacerbated by the hurricane and the subsequent flooding. This is, or has become, one of the ways in which we are able to speak very directly about inequity, both in the conditions that were at play beforehand and in what happened after it. We have a little poll question that I'm going to ask folks to do. Which policy most aggravated the disparity between the circumstances of Black and white New Orleans? Is it A, Plessy versus Ferguson, separate but equal? Is it B, post-World War II housing policies? Or is it C, levy placement and land constraints? And I believe you're able to answer the poll. I'll give folks a moment to go ahead and answer. We're seeing some people answering. I'll invite folks to keep answering if you haven't had a chance to do it yet. No Googling. I see some of you. All right, maybe another 10 seconds or so. Any last minute folks who want to answer the poll? All right, I think we're at 69% voted. All right, 72. I'll give it the quick countdown. See if we can get to 80. Couple seconds. All right, let's stop it there. All right, if we could show the results. Great. So folks are able to see the results there. We had about 35% say Plessy versus Ferguson. We had 29% say post-World War II policies, and 35% say levy placement and land constraints. So I want to just name that all of these are factors, obviously, in what happened there, and that there is some evidence for all of them playing a role. One of the things that New Orleans did better than most was to remain a really multi-racially mixed community, and to have especially African Americans living in neighborhoods with whites. Even if there were social separations, they still lived in the same areas, and part of that was due to the levy placements and some land constraints, but also that after Plessy versus Ferguson, there wasn't the same kind of flight and separation that there were in other places. What really made the difference were the post-World War II housing policies. These policies that did not allow blacks to purchase housing in areas outside of areas within New Orleans, and many of them couldn't go to the surrounding areas as well. And so whether or not you had money or had resources to purchase a home, you couldn't purchase it in other places. And as whites who lived in those areas were able to, they eventually moved out. And so you had a white flight from certain areas of New Orleans, and had a concentration both of African Americans and other people of color. And as those housing policies, you saw some of the African Americans with more means also leave, and so you ended up with a concentration of poverty and a concentration of race in a few places, and that's what we saw in the difference in circumstances between black and white New Orleans. The places where they were concentrated were also the places in the city that were the least ready for what happened and took the brunt of the flooding and the persistent flooding after the storm. So I wanted to bring this example up because it gives us a tale to tell about the history that affects the circumstances. So while the Katrina is about a decade old, the policies that really affected it are closer to 70 years old. And that we have sometimes to trace back the impacts of policies and what communities have made in terms of choices collectively or separately to see why folks are in the circumstances that they find themselves in the present. I hope that that was a helpful example. Let's talk health disparities. So we see health disparities as differences in the incidence and prevalence of health conditions and health status between groups based on race, economic status, sexual orientation, gender, disability status, geographic location, some combination of these, and if the slide was longer, I would add more things on there. This has really been a way for us to talk about how the health conditions and health status between groups are different. And it's important for us to note that differences don't necessarily equate to inequities. And some of these differences are things that we can address easily and some things that we can't address as easily. But it's important that we start with this language because it is the bit of language that most often is convoluted or combined with health equity. So health disparities versus health equity. First, I want to just say up front that there's this false dichotomy as if these two things have no concurrence, like that they're not happening in the same place, and that they are really not pitted against one another. We should be able to work on health disparities and or health equity. It's not a case where one chooses one or the other completely, and that you're not necessarily doing health disparities work or health equity work if you're doing health disparities work. Health equity cannot be a new label. It's not the flavor of the month. We can't just add it to what we've been doing before and say now we are health equity champions. And that these are two really important fronts. We need to address the disparities that exist today and really address the suffering and the difference in health status of the folks who are directly in front of us. And we also need to address the causes of the inequities that we're seeing and the causes of the disparities that are there. And that's where we really start to think about health equity, is when we start asking the questions why and how and where is it that this came from. And I want to harken back to the slides we had before. We have to be willing to see it. Our friends from Healthy People 2020 have a good definition, and it's one that we like to share. Health equity is achieving the highest level of health for all people. And I like this definition because it's saying that all people can achieve that highest level of health. And so that's a very positive definition for me. The second definition also goes a little bit deeper and helps us to think about some of the analysis that I like to address avoidable inequalities by equalizing the conditions for health for all groups that have experienced such and historical injustices. So the example I gave around community had all three of those: avoidable inequities or inequalities, experience socioeconomic disadvantage, and historical injustices in terms of the policies that were in place. And so we have to be about addressing those inequalities and equalizing the conditions that have been brought to disadvantage and the injustices. And that often entails taking on larger systems and larger groups than perhaps we have done in some of the other work. It also means that we have to go deeper than why someone is suffering today and really thinking about what has happened to cause that suffering before. Our friends at PolicyLink also gave us a good definition for equity. They go right to the bare bones: just and fair inclusion. And the reason why we include this definition is that we have to be thinking about health equity in the context of broader equity, that an equitable society is one in which all can participate and prosper, and that the goals of equity must be to create conditions that allow all to reach their full potential. In short, equity creates a path from hope to change. For me, this piece about reaching full potential speaks directly to health, and that if we are helping folks to reach equitable and high levels of their health potential, then they can reach their other potential around the things that they want to do and really participate in society and prosper in the ways that they would want. We will come back to these definitions a couple times, and so if you're hitting, print screen right now, don't worry. So here's my favorite way of describing the difference between equality and equity. At some point, we might have all been the little guy there in the left-hand side that can't quite see over the fence. And then we've got a guy in the middle who can see over the fence but not as much. And then the third one has a great view, can see the whole field, isn't straining to look over the fence. And if we think about our allotment of resources as giving equal opportunity to everyone and giving equal resources to everyone, we end up with the conditions that you see there on the left, where those who can already are and are doing better, Those who need a little help are able to see, and those who need a lot of help aren't able to participate, and in this case aren't able to see the game at all. Equity means giving people what they need to have an equal outcome. And so this is where everyone gets to see. And so appropriate distribution of resources. I know some of you are thinking, oh my, couldn't we just give more resources to the little guy on the right without taking it from the little guy on the left? This is one of our challenges. I know that there are people out there who think we should just be looking for more resources. I like to say to you that the prospects for additional resources at the level that would need to really address equity in public health are not coming. And so it's up to us to really think about how do we apportion the resources that we have, how do we redistribute our attention, our resources, and our effort to maximize equity for the populations that we serve. And it may mean that we need to change some of who we serve and how we serve to be able to serve more equitably. This brings up some really hard questions. Outcomes. Are the outcomes the same for the folks who we are trying to serve? Is that something that we are trying to do? Are we honestly focused on those outcomes being equitable? Resources. Do we have the resources that we would need, and can we work with the resources that we have? I like to think that in the future we'd be able to get some resources to help, but we also are faced with the reality that there are many other things that are pulling at those dollars. Even within public health, there are many other things pulling at those dollars, so we really have to be focused on the resources at hand. And then this question of redistribution versus new resources. It's a tough conversation in many communities, and in the smaller the community is, the action is to be had up front, that if we really want to address equity, we will need to change how resources are being used. And that may mean that shifting who's receiving the benefit of the resources that we already have. So I want to talk about another example. This is West Harlem, Morningside, kind of in the 140s, maybe somewhere around there. I know some of you recognize that picture. Our friends in this neighborhood experienced or several years ago, they noticed that they were experiencing an amazingly high rate of asthma, and that the air pollution in their neighborhood was exceedingly bad. There are many sources of that air pollution, one of which I think you can see in the pictures, the water treatment plant that is right there in the neighborhood on the river. This water treatment plant was planned for probably about 60-something years ago. Construction started in 1972. It came online in the 80s, and right away the neighborhood noticed that there was a horrible smell in the air, that people were having itchy eyes and coughing, that many of the residents started basically airproofing their homes and wouldn't open their windows, would put the rag under the door to try to keep that smell out of their homes, and that folks really weren't using the outdoor space. They weren't spending time outside. They basically went to work and came home and got inside their homes. And the young people also went right from school to home and weren't really outside. And so the picture here is what happened when that neighborhood addressed the issues with the community and put in a park as well, and started to have young people actually use the park. But I bring this up because one of the things that happened is that this plan took place long before the community had a chance to talk about it. They were not able to participate in the planning process by design. The folks that gave the permit did not include the community, and then in some ways purposefully put the plant in a community that did not have political power. The plant was originally supposed to be in the 70s on the Upper West Side. where now there's a huge condo complex by one of our presidential candidates, Mr. Trump. No connection with this. It was long before he was there. But the community members who started to look at the issues noticed that there had been 30, 40 years of keeping the community out of the conversation and not having them be part of the planning process. And so that while they were addressing the immediate needs and concerns in terms of how much pollution was being released into the neighborhood and that they needed to have the water treatment plant and some of the other sites in that neighborhood take out some of the things that were polluting the air and do a better job at not polluting, they also needed to address the lack of presence in the policy making that led to the construction of that plant for its siting and construction in their neighborhood to start with. And this meant that there was a health equity question there. It wasn't just about difference in how people were having asthma, but also difference in how folks in that neighborhood were treated by the city, by the park department, by the permitting process. It highlighted how residents needed to be deeply engaged and how the new sunshine laws, I think they passed in something like the 60s, were finally able to shed light on the decision making that made this happen in that community. They are doing better, but it's a continuing fight to ensure that their community has the kind of air it should have. And for us in thinking about health equity, it's not that they would choose to not address asthma and the young people who are growing up in that community and air pollution in that community because they wanted to address the historical ills. It's that they had to do both. They had to work on changing the conditions that people were facing in the present and ensuring that the things that were causing those conditions wouldn't persist in the future. And that idea that these are conditions that persist and that there are mechanisms that are causing them to persist is what really makes this a health equity issue. That this is not happening in some other place and it purposely was happening in this particular space. So we've got a question. Love to use this slide, so the health ed graphic, but someone approached me stating that it was disrespectful because it was all white children. What do you think? Now, when I look at that slide, I don't know the color or race of the children. If we can, I'm going to backslide to this. I'm Cape Verdean, and I'm in the room with a couple folks with some Latino background. We could easily be that. And it also might be something for you to think about that health equity, especially around socioeconomic class, has nothing to do with race. And I would say back to folks that it's important for us to know who is actually suffering and who the folks that are really paying for the kinds of things that are being done. So who is really being harmed, and that the vulnerable population may not look like who we've always thought it looked like, and it may be folks who we need to support as well. Thank you for the question. That was great. Health equity also asks us to look upstream, just as the folks in West Harlem, Morningside, had to look and see where this historic pollution was coming from, and that the decisions that put that plant in their neighborhood were a lot further up from their neighborhood than around the corner. We have to be thinking about what's upstream, what are the causes of the disparities that we're seeing, what are the mechanisms that are in place, and what are the policies that cause them to persist. And we'll keep talking a little bit about this upstream approach, because if we're really downstream, then we're thinking about the disparities that we see up front. And if we go upstream, we can really address why those disparities are in place and stop them from happening instead of just addressing them after they have. So I mentioned that we would see that definition again. So those of you who wanted to print screen, this is another opportunity to do that, or write it down, or you can just go to the Healthy People 2020 website and see that there. All right. So, as I mentioned, there are 4 key questions. These 4 key questions are really important in terms of health equity because it is about the folks who are benefiting as well as the folks who are harmed, and who's leading the fight and who's making the decisions. These 4 questions also have an impact on how we address health equities. And so we're going to do an exercise that helps us think about these questions in real life, and we'll take a topic that I think is familiar to most and one that's easy to grasp, and then I'll show you some examples of ones that maybe are a little bit more difficult. I'll start with just talking a little bit about who benefits. It's really easy to think about who benefits as evildoers, or the people who are purposely causing the inequity. What we really are looking for are, if there are some direct causal relationships with a particular set of folks, let's name those. But let's also name all the other groups that benefit from the way that things are. Who benefits by a group being not a part of the process, by a group suffering the inequities in health in their neighborhood? Who benefits by not having to address the problem just as much as the folks who benefit from causing the problem? And that this definition has to be really broad because it helps us to think about where we might be able to impact the changes that we're looking to do. Who pays or who is harmed? I like to really think about who is harmed. It's easy to say everyone, and it may be something that you run into in your communities that folks will say, well, everyone is hurt by this. And it's not that that isn't true, but we also want to be very specific because this will relate back to the data that I talked about in the beginning, and it also will relate to the kinds of allies and levers that you'll have based on the populations that you address and the folks that you see are being harmed. And that it's not just people, it's institutions, it's practices, it's who are all the ways in which communities are being harmed by this inequity, and are there people who are disproportionately having to pay for that inequity. Who leads? And this is typically you're thinking about who leads in terms of who's fighting against that inequity, but there also may be people who are leading for the status quo, the folks who are leading to keep things as they are, or perhaps are the opposition to the efforts that you're doing. And last but not least, and separating this out to who decides, where are the leverage points that are decisions that can be impacted? Who are the folks who are making those decisions? And it's easy to say City Hall or the State House, but really try to get specific to who those folks are, because that helps you also then to think about how you leverage the relationships that you have with them and the relationships that you have with their allies, and also how you might go about building those relationships and who you need to target for the kind of change that you want. So I want to stop there and see if there are a couple questions or anything that we want to address. Somebody asked, isn't racism a primary driver towards health inequity? It absolutely is, and that's why we started in the beginning saying that we need to have an analysis on race, power, and poverty. It's just not the only one. It's just not the only one. And I want to make sure that I say that because we're in a moment in the next 20 years where the idea of using the term minority population might not actually fit what we actually see, and that some of these inequities may persist even when communities are no longer the minority population. And so we don't want to just be thinking about race, or just be thinking about socioeconomic status, or just be thinking about immigrant status. We want to really be able to level an analysis that goes across all of those. The primacy of race is important, and so I really appreciate the question, and that we really should make sure that we're making that analysis. It is, for our country, one of the spaces that we have to absolutely address. But so is poverty, and I want to make sure that we name that poverty also plays a role, and that poverty cuts across socioeconomic, cuts across race and ethnicity in this country in ways that we don't always appreciate. Thank you for that question. Do we have another one? If folks have a question that they want, please go ahead and send it. We'll take a break after the next set of slides to address some questions also. So I want to move forward with an example of how we use these questions to begin a process of addressing health equity. We're going to use our friends tobacco. I know some of you are over the moon that we're going to be talking tobacco, and some of you are like, oh, we've done this all the time. I'm going to use tobacco because it is a fairly easy one to start the conversation, but has a lot of pieces and parts that are interesting for this kind of analysis. So I'm going to ask you to use your chat box to answer the question, who benefits from how tobacco is available and is being marketed currently? Who benefits from how tobacco and tobacco products are being marketed and is available currently? And I'll give you about a minute or so to add some answers into that chat box there. And please feel free to be completely explicit, and there are no wrong answers. And anything that you're like, well, that's obvious, please put the obvious ones down too. Keep going, another 30 seconds. Keep going. Okay. Okay, try to wrap up on that one. I'm going to give you a few of what I've seen so far, and we'll also name some that aren't on there. So the most obvious one is the tobacco companies. These are our friends who've been making tobacco and other products, and they obviously are making lots of money from it. Some folks will name lobbyists and politicians. So as long as there's a need for tobacco companies to influence political processes, lobbyists have a job, and politicians have a way to get some donations. And some folks will name that as a pretty obvious set of groups that benefit. Some folks talked about convenience stores and corner stores and retailers. I would add to that list wholesalers. So the tobacco companies will give wholesalers a price break to carry their products and to distribute them. So distributors also are getting that. Convenience stores are often paid to have tobacco advertising and to have lots of different products available to the populations that they serve. And so when you're trying to get someone to remove tobacco products from their corner store, you're also taking away some of their revenue, which is something that folks need to understand as well. And last but not least, right now smokers are some of the folks who are benefiting as well. They can get a pack of smokes pretty much anywhere. It's universally available, and they are finding places where they can get it cheaply and places where they can use the product. One really good one is the healthcare industry benefits. And this is a good example of how we want to make sure that we're naming some of the folks in the who benefits that maybe we don't always think about. So healthcare industry, health insurers, and so forth. And why would we put them in the benefits place? Well, there are many folks who are using their healthcare benefits to address a preventable disease in terms of tobacco and what tobacco exacerbates in the body. And many of the folks who are dying every year of tobacco-related illnesses are some of the people who are paying into and then supporting and paying the healthcare system. I'm not saying to you that you're going to go out to your local hospital and say, hey, you benefit, but they would recognize and realize that there are folks there who are being, so that they are receiving some benefit from the inordinate amount of folks who are showing up at their doors because of tobacco-related illness. So someone asked if we can further expound upon the statement that you made earlier, socioeconomic status doesn't have to do with race. I was saying that it's not that where race isn't the only thing. Socioeconomic status cuts across race, ethnicity, that folks are poor in every race, every ethnicity, etc. Hope that clears that up. I want to ask folks to think a little bit about who is harmed by the way that tobacco is distributed, is marketed, is available. So who is harmed in that second box in the who pays, but who is harmed? And we'll give you a chance again to use your chat box to answer that question. All right, we've got 3 answers so far, 4 answers. Keep going, keep going. And again, feel free to be obvious. And it can be some of the people that we named in the first box in terms of who benefits. Who is harmed by that? Someone said the economy. That's great. That's a really good example that it's not necessarily just a group of people, but something about those people and the way that they interact can also be harmed by this. We got some more answers coming. I'll give you another 30 seconds or so to try to add a few more answers to that process. Keep going, keep going. So a really good example of a group that maybe straddles both of these, the who benefits and who is harmed, are tobacco farmers. So if I'm a tobacco farmer, or I'm a farmer that's or someone who's picking tobacco, I am both benefiting in terms of economically benefiting, but I may also be harmed by the pesticides and the other things that are being used to grow and harvest that particular plant. So I think we've slowed down in terms of the number of answers there. Let's take a look at some of what folks said. So smokers, lots of smokers, a lot of folks put on smokers there. In most of our tobacco work, we tend to not be particularly anti-smoker, mostly because they are the ones that are being harmed, and we have no interest in targeting people who are being harmed and are the vulnerable. We actually want to be helpful and to engage and involve smokers in it. The families of smokers, really deeply important that, you know, secondhand smoke, and I often think about third-hand smoke, where it's not that somebody's blowing it in my face, it's that they were outside and came in smelling like all of that smoke and brought all of that in with them. The people around the smokers, and the folks said children. We often are faced with scenes where people are pushing a stroller while smoking a cigarette. That child can't get away. Parents and others who smoke in a home where there are children present, often those children can't get away. People who live next to smokers, maybe in the apartment next door, the apartment below or above, who are getting the ill effects of the smoke permeating through the walls. Targeted groups, youth, minorities, LGBT, etc. The tobacco companies have for a long time been purposefully targeting young people and minority groups and the LGBTQ community. They think of these groups as their future market and that they can deceptively sell their products to this group. And so we also see that these groups are disproportionately feeling the harm of exposure to tobacco and tobacco products. Healthcare costs and the economy and the taxpayer. So as we talked about, some of the folks in healthcare also recognize that they are being harmed by the way in which people are addicted to and to tobacco products. because those costs show up at their door. So when you come in for an emergency room visit because of a situation that has been exacerbated by smoking and that you can't stop smoking and it keeps exacerbating, that repeat business to the ER is very costly for the healthcare system. Insurers are paying more, and hospitals and emergency rooms are also dealing with greater costs because of that factor. And that this often then gets passed on to the taxpayer for folks who are in the public health systems or in a health system that's being paid by the taxpayer. There are also costs to the taxpayer about the ways in which these costs to healthcare also raise the costs for everyone, and that's both in your insurance plan and in your local hospital and the cost of receiving care. Thank you all for some wonderful answers and participation in those first two. And so we started to kind of name some groups and some spaces. And are there any unusual or surprising groups that we've named that folks didn't think about? I'll just ask you to use that chat box again. Or is there a group that you have that you thought about that hasn't popped up yet? So I give folks about 30 seconds to see if anything comes up. Any unusual groups? So one group said, one person said the LGBTQ community, yeah, that they may not have thought about that group. The taxpayer, yeah, absolutely. People who are vulnerable to addiction in general, and this is something that's we're starting to really think about, that folks who have been addicted to other substances often are using smoking as a way to cope as well, and that can exacerbate some of the health effects that they're already experiencing, as well as can be something that persists long after their previous addictions have passed or have ceased to be as much of a problem. So definitely there. Thank you for those. I want to ask you now to think about who leads. So who leads on this issue? And think about it on both sides of the question. Who leads in terms of fighting against the ways in which tobacco is marketed and available, and who leads to make that actually possible? And we'll ask you to, again, use your chat box to add folks to the screen there. I'll give you another 35, 45 seconds. Keep going. Keep going. About 10 more seconds. Try to add. So some folks have talked about lobbyists, and some folks have talked about the tobacco industry itself and the tobacco farmers unions. That's a really good one there. Sometimes we forget how pervasive the tobacco farming industry is, and Connecticut is a state close to where we are right now in terms of Massachusetts. It has lots of tobacco farmers, but there's tobacco farming up and down the East Coast and around the country and literally around the world. So many of these interests are not concentrated in one place, but really are in lots of different places. About 10 seconds to see if anybody has something else to add. Certainly, some folks said on there the consumers themselves, that smokers often are the people who are trying to push against any kinds of laws or ordinances that limit where tobacco can be sold and how it can be used. The suppliers, distributors, wholesalers, the retailers. Some of you may live in states where restaurants are not tobacco free, and certainly when that was a fight in some states, they saw that the restaurants themselves were getting together to fight against that particular set of ordinances and laws, and some of their patrons were also. For some of you who may not be living in states where tobacco is not available in restaurants, you'll be glad to know that the restaurants do just fine without tobacco. So let's see some of who folks said. So the advocates, for sure. Legislators, and I like to point out elected officials because we forget how much power a county administrator has, a school committee person, the city council person, the alderwoman. These folks that are elected at the local level can really affect the quality of life in those spaces, and so they can be really amazing advocates, but they can also really be challenging opponents. And so if we can build the relationships with these folks and ally ourselves with them, they can also help in the fight. Community members, youth, and parents, we saw young people a bunch of times in terms of answers, and young people, who are striving for change. Really important that the young people we mentioned in the previous question were being targeted by the tobacco companies. And so if you can think about engaging and involving communities that are being the targets of the inequities, then they become a powerful voice, not only for change in their own community, but for making change with the people who perhaps haven't seen the inequity or haven't noticed that they were benefiting from it. And also directly with the folks who are part of the causes or exacerbating the conditions that persist that cause the inequity. And parents, and then parents also a really powerful group of folks. Boards of health, the healthcare community and public health. I think we're familiar with the power that public health and boards of health have in terms of ordinances and spaces where people can smoke. And but healthcare also can be a really powerful support and ally to the efforts on the ground, both with how they're able to provide data and as well in terms of the kinds of relationships that they have with the powerful folks in that particular community. And also that healthcare, and this is including communities, health centers, hospitals, insurance companies, private physicians, physician groups. These are all powerful players in your community. They're all people who live in the communities in and around where you might be serving, and that they have at stake also how people think about them in terms of healthcare and in terms of where they get their care. All right. Last but not least, who decides? And this one last time, and I ask you to go to your chat box. Who decides on issues of how tobacco is allowed to be marketed and where you can find and get tobacco? Who decides on that? We'll give folks another maybe 35 to 40 seconds to try to answer that. Who decides? Keep going. Keep going. Some of you have been on webinars before and know that I can see your names, so I might just ask you for an answer, Tamaki West. For those who don't know, Tamaki is one of our colleagues. All right, about 10 seconds. See if you can add a couple answers. Who decides? We see a lot of government and local convenience store owners, lobbyists, health agents of cities and towns, boards of health, retailers, policymakers, and that's really the kinds of groups we're talking about. I split them here into different levels. So we've got the legislature and the elected officials who are passing laws and ordinances. We also have the power of boards of health to promulgate regulation, and these regulations can be powerful supports for public health, and especially in an issue like tobacco. And so really thinking about who is part of your Board of Health and what kind of relationship you can build and have with the Board of Health in the fights that you're taking on in your community can be a really powerful lever for the work that you're doing. I added the courts in there, that there are legal battles that are being fought and continue to be fought around these questions, and that they are a powerful space for change in terms of the health of communities. And then federal agencies. I think there's a role for federal agencies, and there's some opportunity to influence how federal agencies look at the issues that we're experiencing in our communities, as well as how the leadership of those agencies and the political structures that support them take on these issues. I want to thank people for going deep in terms of these questions and really participating. I really appreciated those answers. We're going to move forward in thinking about some more examples, but I wanted to make sure that folks had a chance to ask any questions before we go to another set of examples. So one question we have is, oftentimes we are forced to prioritize which population or factor to focus on due to the funding or other constraint. How do you address that in the context of health equity? Wonderful question. It begets two really important pieces. One, why is it that you're being forced to choose and prioritize? That itself can be an equity issue. And then secondly, is there a population that is suffering an equity at a greater pace or greater size than other communities? So when you look at the disparities in your community, when you're looking at the differences in health outcomes, are there communities that are suffering to a greater extent, are being visited upon or have been visited upon by certain inequities for a long time? Are there persistent inequities that you've noticed over time? And are there policies that that help to keep those inequities in place? And this is where it's important to do this four-question analysis, that you can surface some levers and some opportunities to address with certain populations that inequity. And then when you're making that decision about prioritizing, you might think both about who is suffering to a greater level, but also where are the opportunities to address that suffering. And I like to say to folks that we play always a long game and a short game, that whether or not we're able to prioritize something does not mean that we're not working on the other pieces, and that the process of empowering a community to address its health, even if you're focused on, let's say, low birth weight, can teach those empowerment, that empowerment to people who are suffering from a different inequity. And so engaging and involving them in addressing one issue builds their capacity to be able to address the other issues, even if you're not able to financially participate in that. And that's also the power of this, keeping this a collaborative process, that we are all engaged in the process of making our communities healthier. Thank you for that wonderful question. So we were really focused with that tobacco example on the who benefits. To be honest, a lot of how tobacco is being addressed is to look at who's benefiting from how things are and trying to change that, whether it's tobacco companies, the corner retailers, etc., and changing the space. And so I wanted to just focus on an example that really talked about the who is harmed and use a lever there that was available to this particular group. These are our friends in Multnomah, Oregon. This is the former program manager for the county health department. His quote was, when we talked about disparities, it was simply reflecting the data. We weren't telling the whole story. We weren't talking about the structural pieces. Until we started to look through a lens of race, power, and poverty, we really weren't moving upstream. Now we're focusing on the conditions that lead to the outcomes we see. And again, this is that health equity lens. We're not just looking at what the data is telling us, we're thinking about why. And we're not just reacting to the disparity that we see, we're really thinking about how do we change the conditions that cause those disparities to happen and cause them to persist. And so in thinking about who was being harmed, the county health department also thought a little bit about what it could do. And so they went through a process to really engage a cross-sector collaboration. So it got community members together across the local area, including aspects of business and government and cultural groups. They screened all of the staff and some of their partners a wonderful video called Unnatural Causes. I'll recommend that to folks if you want to take a moment to jot it down, and you can look it up. It might even be on YouTube. It's definitely available online, and you're able to screen it. It has some wonderful vignettes and stories and some really powerful information, and it frames these issues in a way that's easily available for explanation. They actually trained their staff to go and facilitate these small group screenings of that unnatural causes as a way to start having conversations about health equity in their community. Over 500 people were part of those processes. And so when they looked at this equity, they thought about and used an equity and empowerment lens. Another way of thinking about the health equity lens is that we should also be thinking about empowering folks. And what they landed on was that there was an opportunity for the county department and the local hospitals to really think about the services, policies, practice, and procedures that they had. Were these equitable? Where were they really not addressing the inequities within what they did? So not just what was happening in their community, but how were they part and parcel of it? And so what came out of it was that the health department developed new partnerships, they applied for new grants, they developed new positions, and they contracted to promote economic development. What they noticed was that the area around them was suffering from low economic opportunity, and that there were communities, especially communities of color, and the specific communities of color that were not participating in the economy and that were being left out. And so they decided that they would proactively focus on that promoting economic development by contracting with local partners for the services that they needed, and specifically with minority contractors, so that they could employ more folks from the communities that they saw were suffering from this specific inequity. And deeply important that they saw this as what they could do. It came out of an analysis of who was being harmed, and that they could do something that was from where they stood. And again, this idea of doing the analysis, some practical steps for all of these, and I wanted to touch base on them now before I go to other examples, because they also follow the same path. Gather the data and disaggregate. And as I told folks in the beginning, you may have to go get some of your own data. If it's not available for a certain population, you may need to do some of that data gathering yourself. The community health assessments that have been done that overlap with the communities and neighborhoods that you're serving, that you're hoping to address, and see if some of that data is there and available, and how you might the data gathering that will happen to better cover, better represent the communities that you are looking for, and that data gathering should also start to give you this ability to disaggregate so you can look at specific communities. This may be as simple as working with your local health departments and some of the hospitals in your area to harmonize or synchronize how they are collecting that data, what kinds of things they are bringing to bear, and where is it that they're asking those questions, so that you get a coverage that fits better what you're doing. Be bold. Have the conversation. Are we doing things in our community that disproportionately impact a specific set of the folks here? Have things been done in the past that disproportionately affected a segment of the community? Are there historic injustices that we need to now address to bring equitable outcomes for everyone in our community? And what does that mean for the folks who have benefited from them? And how have they benefited from them? And that's one of the spaces that a lot of communities get stuck in, is naming what that benefit has been. But that also then allows you to do a real examination of what that benefit has, how that benefit has empowered the people who have it now, and what it means to not have that available. That starts to do this, having an analysis on race, power, and poverty. Many of the communities that are starting to address issues of health equity are doing so in the midst of this change in terms of demographics. The state I live in 35 years ago was 92% white European Caucasian descent. It's now something in the 60s in terms of that population. That is a massive change within a lifetime of the population of an entire state. And that has effects on how people perceive issues of race, power, and poverty. It also has changed economically in drastic ways, that some of the ways in which people were able to make a living 30 years ago just no longer exist. And really important that we name those things, because that is part of what communities are suffering. And if we're doing that analysis, then also think about ways in which race has played a part in how that power and poverty have happened in the community. Examine existing disparities. So the stuff that is already being highlighted as a disparity, how, who, how does it persist? Asking those 4 questions. Making sure that we're looking upstream. It's not just that our friends in Harlem were experiencing higher rates of asthma today. It's that this had persisted for the balance of the time that the plant had been in place, and that people had suffered without knowing why, and that decisions had been made long before the community was even aware of them. Making sure that we look upstream also ensures that we are not just changing today, but we are changing the future. It's not a Band-Aid. It's really about helping communities to heal. And I mentioned answering those 4 key questions. My advice is that you return to those 4 key questions from time to time to re-examine the disparities and to look at who else might be part of the issues that you're trying to address. And that if you chose a particular population or practice within the answers to those 4 questions to focus your efforts, you might go and choose a different one to try to move things forward. Be bold again, and this is bold on both parts, because it's not just about talking, it's really about targeting the change, being able to name what that change is going to be and to be working towards it. Finding allies and points of leverage we've been talking about. This means engaging the communities also who are most vulnerable to the inequities and the people who have been suffering. Plan and act. And I put the comma there because it's important that we plan first, but it's also important that we act. This can't be something that sits on a shelf. It can't be something that is nice as a drawing on the wall, but has no life in our communities. And we will be much more impactful if people are seeing us as able to and willing to act. I want to give a few examples of exactly that. One of the toughest ones to kind of name is who leads, and to really act in that space. So this really is important because it also brings up some of what we've been talking about in terms of collaboration and partnership. Cross-sector collaboration to address health equity can bring you amazing partners, some usual partners and some unusual partners. Businessmen, people who are leaders within the legislature sometimes are seen as apart from, or maybe not your usual partner when you're looking at an equity question for a small population of your community, but they can be great champions. Folks in different industries, people who are part of your philanthropic community, part of your education and academic community, folks who are part of the civil service community. And I would extend to you that veterans are a perfect group to engage in these issues because they often have had the kinds of experiences of serving with people across difference that can help communities build bonds within spaces where there are separations across difference. Including the voice and participation of the affected group of people. If you do nothing else in trying to address health equity, make sure that you're engaging the people who are actually part of the inequity, the folks who are being affected by that inequity, and that they are not just being told that things are going to happen, but that they are part of deciding what happens that addresses the inequity that they are suffering. Deeply important that we are building relationships with the group, but more important that they are part and parcel of the analysis up front and the decisions about action and then the implementation of that action. We'll take an example about what that looks like coming up. Our friends in Greater Worcester had a community health improvement plan. One of the goals, and they had big goals, one of the goals was to improve population health by eliminating institutional racism and the pathology of oppression and discrimination by promoting equitable access to and use of health-promoting resources in the community and significantly reducing the structural and environmental factors that contribute to health disparities. Huge goal. I looked at this and was like, how are you going to do it? They were amazingly specific about what it would take to do this. Among the things that they named, and these are listed here, I won't go through all of them, were two amazing and important pieces. One, they recognized that they needed to have a group of grassroots adult and young leaders who were prepared to be part of the solution, that they were going to receive the training that they needed to become leaders in their communities around the issues that affected them. And so 522 recruit and organize a cohort of 100 grassroots leaders, including 25 youth from key populations and sectors, and 523 enhance and develop training programs for grassroots leaders to develop leadership knowledge and skills in community and systems change for public health. Knowing that this is a continuing process and that these are the people who are going to be part of that community going forward, investing in their leadership so that they would be part of who you would put in that box who leads, and that they are leading by being well trained and informed on the things that are affecting them and affecting their community. So as you're thinking about how to engage and address some of the health equity and some of the challenges that come up around how you're going to get a population to really be part of the solution, making sure that you are planning for and addressing the needs that folks would be folks have in terms of being able to participate at a high level. One last one is who decides, and I think we're going to take questions after. This is a really tough one, but there are some good examples of how we engage and involve the who decides. I'm going to say to you that there are two places. One is who decides already in making the decisions within the people you're trying to address. And so we've talked about legislatures and boards of health and elected officials and folks at the local level in your board of health. But the other decision makers that are important are the decision makers on your side. And so you've got to make sure that you're engaging the communities that are being affected by the health equity or health inequity in the decision making about what happens to address it. And so this means that you're recruiting and engaging folks, and they are part of the process from the beginning, that engagement isn't someone telling them what's going on or going and asking them questions in a focus group and bringing that back to your planning meeting, but that they are actually authentically engaged with you, that there isn't something that's happening about them that they're not a part of. And that may mean that you have to restructure your coalition or find ways in which their coalition can include some of those vulnerable populations so that their voices are in the efforts from the beginning, that they are included in the decision-making processes, whether those are about grants or about stances, that they are able to be part of how the decisions are not only made, but how the decisions are seen. And this is where that last one, that empower, becomes really important. The communities that are being affected by these inequities are being affected because of their lack of power. And power in the past through historical injustices, socioeconomic disadvantage, and power in the present in terms of some of the avoidable inequities. And so if you can start by changing that dynamic, that they are empowered, that they have power in how things are going to happen to address the inequities that they're experiencing, that can be a really important step and a bold first step to doing it, to really addressing health equity. All of this is supported and buttressed by deep relationships that are respectful and inclusive and that build over time. You're not going to walk into a community that has historically been suffering an inequity and then automatically have them step forward and join you in the process of addressing that inequity. You'll be building these relationships over time, and you really want to make sure that you engage folks before you need to ask them to do something. So really build those relationships, get out there. If there's a community that you see and your data is disproportionately affected by something, get involved with them long before you have an answer for them so that they can be part of formulating that answer. And I know that's a lot to think about. We thought about that as well, and we wanted to make sure that you'd have an opportunity to address that. And so I want to point you to the Health Equity Series Module 2, Engaging and Empowering Priority Communities, a webinar on March 23rd from 1 to 2:30, where we are going to dive deep into how do we empower and engage the communities that are suffering these inequities, and what does it really mean to have their authentic participation and engagement, and maybe some strategies on helping to make that happen when you're facing some challenges to how that works in your community. This idea of power is exemplified by this empowering priorities, but there are other power dynamics. We have a live training, this is an in-person training on April 27th from 1 to 4, and this is the third in our series. It's called Power Dynamics. It's going to be preceded on the same day, meaning you can come for the whole day and take a training on facilitated leadership, and that's in the morning from 9 to 12. Those are happening together, so you can register for them both, and you'll have a great opportunity to think about facilitative leadership and then think about how it applies in the spaces where power dynamics maybe are forcing you to make some different changes in your community. I want to ask to see if there are any last-minute questions before we close out. We've got one here. Would it be possible or beneficial to partner with those who benefit from the issue? Wonderful question. Absolutely, absolutely. One of the things that that can be really powerful is to help those who are currently benefiting. Oftentimes they are not the causes and they are not part of the reasons why the inequity persists, but they don't even know that they are benefiting from it. They can definitely be powerful voices, and they oftentimes have the relationships with the people who decide, and so they can be really powerful to as allies and to maybe open some doors for the efforts that you're trying to do. Really wonderful question. We'll see if we have maybe one or two more. Let's see, we're getting. So the question is, the Worcester Health System addressed eliminating institutional racism. How do we as public health practitioners embark upon this? Wonderful question. I think what they did really well was to think about engaging not just the public health system in terms of the operatives within the official public health system, but the broader idea of a public health system that includes those cross-sectional partnerships that allow them to be thinking about institutional racism both from within and outside of not only their institution, but the multiple institutions within their community. Wonderful question. See if we have time for one more. No, I think that's it. I want to thank folks for jumping on this particular opportunity, and I hope to see or hear you in the next series, Module 2 on March 23rd and Module 3 on April 27th.
And thank you, Mo, so much for that great and informative presentation. And as a reminder, he just told you the dates. This is just the beginning of the conversation, so please keep the questions coming in. You know, you have Mo's contact info and our contact info. We can definitely follow up, and he also has his follow-up webinar and training coming up as well. We also have on the screen here this policy and practice report that's available through our website, hria.org, that really is talking about embracing equity and community health improvement. So for those that are engaging in that process, thinking about it, or just really interested and curious about this, please check out that report, and we will also send a link of it when we do some follow-up. And additionally, we wanted to share a resource before closing out. Health Resources in Action has just recently acquired this amazing new project called Massachusetts Working on Wellness, which is an opportunity for Massachusetts employers who are seeking support in building worksite wellness initiatives. So, you know, this is a project or initiative of the Department of Public Health in Massachusetts here in collaboration with our organization, Health Resources in Action and Advancing Wellness. And the goal is to support employers to successfully implement comprehensive evidence-based worksite health initiatives so that we can help support a work environment that enables all employees to engage in healthy behaviors. So, you know, it's so connected to the topic today because we know if there's some things going on in people's lives that are really weighing them down or adding more stress, it's really important where most likely where they spend the majority of their time, which is work, is that they're getting the support they need in order to be as healthy as they can. So this project, just so you know, can provide up to $10,000 in seed funding, comprehensive training, and ongoing technical assistance so that it can support employers to adopt these sustainable strategies. So we really encourage you to go on their website, mawow.org, and this next round of applications is due March 4th. They're going to have one other round in a few months, but we wanted to let you know of this great opportunity. And per usual, just to close out this wonderful presentation today with really good questions and content, we really encourage you to check out our website, Twitter, LinkedIn, email us. You have Mo's contact info that was shared at the beginning. I will also follow up with more info. We really want to keep this conversation going because it is so critical. So thank you all so much. Thank you, Mo, for a wonderful. Thank you to the Massachusetts Department of Public Health for making this webinar and the subsequent ones available for free to you all. So we hope you have a wonderful afternoon and we'll be in touch soon. Thank you.